Good evening. Our study is on comparison of efficacy of energy titrated corneal collagen cross-linking in thin corneas, that is sub 400 micrometer, with standard accelerated C3R protocol in treatment of keratoconus. So, corneal collagen cross-linking is a minimally invasive procedure where riboflavin, a photosensitizer, and UVA light will help to induce the formation of strong chemical bonds between collagen fibrils in the cornea. So previously, above 400 micrometer, we are using conventional method and accelerated method. Now there are so many methods for sub 400 protocols: hypoosmolar riboflavin usage of hypoosmolar riboflavin solution, transepithelial collagen cross-linking, contact lens assisted collagen cross-linking, M protocol, and epithelial island cross-linking method. In our study, we are doing the procedure as after the epithelium removal, the intraoperative pachymetry is measured, and UVA irradiation at 9 milliwatt per centimeter square with irradiation time individually adapted to adjust the fluence according to an open source online calculator. So, in energy titrated, we are the intensity and duration adjusted to maintain safe fluence depending on the corneal thickness, and we are using less than 5.4 joules per centimeter square. And accelerated C3R, we uses higher UVA irradiance for shorter duration to achieve the same total energy. So the study is done to compare the efficacy of energy titrated corneal collagen cross-linking in thin corneas with standard accelerated C3R protocol. So this is a prospective study design done in period of January 2024 to June 2025 in a tertiary eye institute in South Kerala, and we aim to include patients who on prospective analysis were found to have progressive keratoconus, and 6-month follow-up was done. So patients are recruited in two groups, 31 eyes in each group. The inclusion criteria include in group 1, that is the patient undergoing energy titrated C3R, the pachymetry between 300 to 400 micrometer is included, and best corrected visual acuity of 6.6 with miniscleral lens trial or spectacles. And in group 2, that is patients undergoing accelerated C3R, a minimum pachymetry of 400 micrometer included, and BCVA 6.6 with miniscleral lens trial or spectacles. So the cases with apical opacity or hydrops and any history of herpetic corneal disease or previous ocular surgery excluded from the study. So coming into the result, the age and sex distribution were equal in both the groups, and comparing the flat keratometry values pre and post procedure, within the group 1, the mean flat keratometry increased, which was not statistically significant, and in group 2, K1 remains essentially unchanged. And in steep keratometry also there is almost stable keratometry pre and post C3R procedure in both the groups, and average keratometry also in group 1, average keratometry increased slightly from 55.2 to 6 plus or minus 6.5 diopter, and in group 2 also values changed minimally from 48.2 to 48.7. So comparing the pachymetry and pre and post procedure, between group analysis reveals significant differences in both baseline and post-operative pachymetry, reflecting both the inclusion criteria and a slightly greater post-procedure thinning in thin corneas, that is the group 1. So coming into discussion, the Farhad Hafezi et al. Study done for 39 eyes, the sub 400 individualized fluent CXL protocol standardizes the treatment in ultra-thin corneas and halted keratoconus progression, and they have done in 1-year follow-up. And Frederick et al. Also study done in sub 400 protocol, 32 eyes with the progressive keratoconus. They also found that the stability of keratoconus after cross-linking in a 1-year follow-up. In our study, we compared both the energy titrated and the accelerated with 31 eyes, and we have also found the comparable efficacy between the two groups, and modifying energy delivery based on corneal thickness is a rational and effective strategy, and we study done in 6 months of follow-up. So concluding, energy titrated C3R protocol is an effective treatment for stabilizing progressive keratoconus in thin corneas. And we also found that the comparable efficacy in halting keratometric progression to the accelerated protocol in thicker corneas. So this is a modified approach successfully expand therapeutic indication for C3R to include patients with corneas previously considered too thin for conventional C3R treatment. These are my references. Thank you.
Thank you, Shahna. And I think you used that protocol by Hafezi et al. only, no?
Yes, yes.
Yes, the results are quite good with that. But when you're presenting a comparative study, discuss your result in terms of primary outcome measures, secondary outcome measures, that gives more value to the study. You discuss all the point, but we didn't know what was your primary outcome measure. And because since it's a comparative study, you have to tell us about the sample size calculation also. Because all the value that you have got significant difference, that may not be useful if the power of study is less than 80. Okay, so you have to calculate sample size when you are presenting a comparative study between two.
Our next presentation